Hi, my name is Kristen Williams. I am a third year doctor of pharmacy candidate, and today I will be presenting my journal club critique on the comparative effectiveness of dexamethasone versus prednisone in children hospitalized with asthma. The authors of this article were Kavita Parikh, Matt Hall, Vinita Mittal, Amanda Montalbano, Jessica Gold, Sanjay Manhat, Karen M. Wilson, and Samir Shah. Background information. Normally, prednisone and its active metabolite, prednisolone, are used to manage acute asthma exacerbations in the dose 1 to 2 milligrams per kilogram per day for 3 to 5 days. Prednisone is dispensed in an oral tablet or syrup and has a bitter taste. It also has a half-life of 12 to 36 hours, requiring twice daily dosing. Recently, dexamethasone was found to be equally effective in treating mild to moderate exacerbations in the emergency department. Dexamethasone is long-acting with a longer half-life than prednisone. It is well absorbed and has a greater affinity for the glucocorticoid receptor. Dexamethasone is more ideal for less adverse events and adherence. The pharmacokinetics and receptor affinity allow it to be 5 times more potent than prednisone. Now for the methods. The objective is to study the comparative effectiveness of dexamethasone versus prednisone or prednisolone in children hospitalized with asthma exacerbations not requiring intensive care. The trial design. This trial is a multi-centered retrospective cohort study using the Pediatric Health Information System. The location of this trial was the Children's Hospital Association in Overland Park, Kansas. IRB approval. This research using a re-identified data set was not considered human subject research according to the policies of the Cincinnati Children's Hospital Medical Center Institutional Review Board. Inclusion. The study included children ages 4 to 17 years old who were hospitalized with a principal diagnosis of asthma between January 1st, 2007 and December 31st, 2012. Exclusion. Children with chronic complex conditions and or intensive care unit management, children with chronic complex conditions and hospitalizations with secondary diagnosis other than asthma that require corticosteroid treatment were excluded. Subjects. Corticosteroid treatment for asthma exacerbation was classified as dexamethasone for children who received dexamethasone only, and classified as prednisone or prednisolone for children who received either prednisone or prednisolone only. The primary endpoint of the study was the length of stay. The secondary input included readmission cost and transfer to the ICU after admission. There was no follow-up. The duration of the study was 5 years, January 1st, 2007 to December 31st, 2012. The population was 1,284 patients. 642 patients received the dexamethasone and 642 patients received prednisone and prednisolone. The arms of the study were the dexamethasone arm and the prednisone/prednisolone arm. Statistical analysis. Characteristics of the exposure groups were summarized by using frequencies and percentages for categorized variables and X2 tests for bivariate comparisons. For further residual confounding by indication, a 1-to-1 ratio propensity score matching strategy was implemented. A multivariable logistic regression model used corticosteroid type dexamethasone versus prednisone as the dependent variable. This shows acceptable discrimination. Those children who received dexamethasone and prednisolone were matched on propensity score using greedy nearest neighbor matching with a caliber set at a quarter of the standard deviation of the logic propensity scores. Matches were forced within hospitals to avoid bias across hospital variability outcome using hierarchical models. The baseline characteristics. Since the p-value is less than 0.5, the length of stay is statistically significant. The dexamethasone group length of stay was shorter than the prednisone group. The cost is also cheaper for dexamethasone, but it's not a significant difference. Readmission was less days in the dexamethasone group than the prednisone group. Primary endpoint. Children who received dexamethasone had a lower length of stay than those who received prednisone or prednisolone. Secondary endpoint. Children who received dexamethasone had a lower index cost of hospitalization with no differences in the transfer to the intensive care unit or readmission rate at 7 and 30 days compared with those who received prednisone or prednisolone. Adverse events. The adverse events included emesis and dehydration. Dexamethasone had less occurrences of emesis in the emergency department with a relative risk of 0.29 or at home with a relative risk of 0.32. No readmissions occurred. For the author's conclusion, dexamethasone can be considered as an alternative to prednisone or prednisolone for children hospitalized for non-intensive care unit management of asthma exacerbations. The results suggested that dexamethasone is a potential treatment alternative for the asthma exacerbation in an inpatient setting. The studies show that children who received dexamethasone were less likely to vomit. The parental preference favored the dexamethasone. The dexamethasone was also more cost-effective in the case of an emergency department asthma exacerbation. There was no difference in the risk of asthma relapse. Studies are consistent with previous emergency department studies that suggest that dexamethasone is a useful alternative. The reported palatability and the need for a shorter course of dexamethasone versus 5 days of prednisone may significantly improve adherence, as the course would likely be completed as an inpatient and negate the need to rely on caregivers to fill the prescription. Therefore, the use of dexamethasone for children hospitalized for non-ICU management may be a reasonable practice in the inpatient setting. In conclusion, authors' limitations included casualty cannot be inferred from the results because this was an observational study. Dexamethasone use varied greatly throughout hospitals, which is justified by the use of propensity score matching. The data source did not permit the assessment of dexamethasone dosing during hospitalization, durations of dexamethasone and prednisone or prednisolone treatment after discharge or compliance. Vomiting was not an accessible outcome, although it was reduced in emergency department trials. Children with high severity illness requiring intensive care unit admission were excluded, and the results were not generalizable to that population. Finally, only tertiary care hospitals were represented in this trial. For the critiques, the strengths. Propensity score matching was a strength of this study. The use of data from the Pediatric Health Information System database eliminated bias. The comparison of dexamethasone to the traditionally used prednisone compares the relevancy of efficacy of dexamethasone to a preferred treatment. Excluding the patient population to tertiary care only supported the indication of a more severe asthma exacerbation. Weaknesses. A major weakness may be the lack of knowledge of determining how many doses of dexamethasone are needed to achieve the same efficacy of prednisone. The study was also limited to 42 of the 222 children's hospitals in the United States, which is only 20%. Summary of primary literature. Previous studies of the use of dexamethasone versus prednisone or prednisolone for mild to moderate exacerbations of asthma in the emergency department setting for discharged children compared 1 to 2 doses of oral dexamethasone or 1 dose of intramuscular dexamethasone with the usual 5-day course of oral prednisone. Qureshi compared 2 doses of oral dexamethasone with 5 days of oral prednisone and found that the 2 doses were equally effective. The 2 doses also had fewer side effects and improved adherence. Gordon found that a single intramuscular dose of dexamethasone did not have a significant difference in the mean total asthma scores for a 4-day follow-up for children discharged from the emergency department with moderate asthma exacerbations. Dexamethasone is now used in clinical practice. Application and conclusion. I think this was a very fair trial. For the most part, the research was thorough and the results reflected upon a well-performed study. This study was effective in fulfilling the points of an observational study. There was little to no bias, and the resources from the PHIS were valid. The study effectively proved that the dexamethasone was more useful than the prednisone or prednisolone in asthmatic children of the emergency department. However, one significant weakness in the study was the failure to evaluate the dose equivalence or efficacy of dexamethasone compared with that of prednisone. Taking a closer look at these values would have given more accurate results when comparing the effectiveness of the two drugs. Also, dosages, frequency, and duration were not thoroughly tested in the study. Adding this key information in future trials would make them more complete. The study was an overall success in assessing the effectiveness of the two drugs. Thank you for listening.